We know that we are struggling when it comes to emergency care. There are lots of challenges that we have both within the hospital and outside the hospital.
The strategy for transforming emergency care is based on 4 key themes. Streaming at the front door, where patients are met at the front door by a senior clinician to direct them to the most appropriate place in the system for their needs. Flow through the emergency department, where patients are transferred to a specialist department for admission or to the acute medical unit or ambulatory care if possible. Safer, the cornerstone of the programme, where wards and departments use scorecards to self-assess and review their performance on a daily basis to improve flow and avoid delays in patient care. And discharge, where patients with a longer length of stay are managed more efficiently to reduce their stay in hospital.
I've recently taken on the role of the navigator. The navigator role is an experienced practitioner who sits at the reception desk, and basically what I do is see and listen to patients who are booking in. The waiting time for the nurse practitioner is about 15 minutes. She should be able to pick you up then. Okay. We've recently had an urgent care practitioner brought into ED from the urgent care centre, so I can stream that patient if I don't think that that patient is appropriate for the emergency department. Listening into what they're presented with, it might be suitable for our RAMAC, our medical outpatient department that would deal with simple things like a DVT. So it's looking at what is the right service for the patient. Should there be an A&E? And if they do need to be A&E, equally, whereabouts in A&E do they need to be seen?
Our aim is to assess patients within 15 minutes. The pilot started in October 2016 and has already shown a positive impact on the same period last year. The work of the emergency department is supported by colleagues in the acute medical unit, which has reconfigured its services to accommodate more patients from ED who do not require a bed.
So one of the initiatives we came up with was introducing a GP assessment area on AMU. So we basically bring our GP admission straight into AMU, so there's no divert into accident emergency. The medical registrar used to take the referrals from ED. They would get the referral, then eventually we would get to know about that patient needing an admission into AMU.
Ambulatory care may also be more appropriate than a hospital admission. They may take referrals from ED and also GPs. Ambulatory care is able to assess, diagnose, treat and discharge 97% of patients within 1 day.
The patients are seen quickly, they're seen by nurse practitioners, a plan of care is put in place and treatment started, and a lot of the times those patients are actually being turned around to go home, so that is relieving pressures not only on the emergency department but within the medical assessment unit as well.
When a patient does require admission, specialist departments work with ED to transfer the patient into their care within 30 minutes. The surgical care group now have processes in place for this transfer.
The improvement's there because we've built up a relationship. We accept that they've been reviewed by a senior colleague in ED and they need some support from another speciality, and we get the doctors to go down. The other area that we've looked at is if a senior colleague in ED deems that a patient requires a subspeciality and there is a bed available, they have the ability to move the patient directly into that bed without them being reviewed by that subspeciality.
As a result of improvements in ambulatory care, diverts to ED have reduced significantly.
Striving for excellence!
Which means that we're trying to enhance our care and maintain high quality standards whilst also managing the patient through what is quite a complex process at times when they come into our emergency care departments and through onto acute admission units and onto base wards.
All in together!
Everybody within the process is involved in this, and this includes our multidisciplinary teams that also come in to affect patient care.
Focus on flow!
Flow is to maintain patients moving through the hospital and having a safe and timely discharge, and in that we include our expected dates of discharge, which actually has improved the flow of the patients quite well through the hospital.
Energise and
ensure that all staff are fully aware of the safer bundle and that we're implementing this on the ward, and that we will bring these out through the huddle, and that every member of staff from the the person as the domestic on the ward through to the consultant on the ward area should be aware of the safer bundles.
Ready to go!
This ensures that all patients have a timely review and that we have made sure that we've completed our discharge processes, including letters, and making sure that pharmacy prescriptions are ready on time and that ambulances and other transport means are booked in a timely manner.
This is the Safer Scorecard. Around 44 wards and departments across the Trust, including community hospitals, now have safer care bundles in place. Once a standard has been consistently achieved, the team selects a new priority to work on together.
So we have now got a system in place. It's called Nerve Center, and we're building up on it on a daily basis. We've just gone live, and what it will do for us is to really give us a list on each hospital and pick up any site, and every ward we will know the number of patients who are actually in that list that we need to go and see. So we will be looking at everyone who's staying for more than 7 days, but particularly what I'm interested in is that group of patients who are medically fit for discharge, who are staying in for no medical reason, and we need to find a way of expediting that. So that list will be made, that will be sent to me as the care group director. I will work with the associate director of nursing and the matrons as well as clinical leads to really find a way of going and seeing them, reviewing them, and making the right judgment.
As part of the discharge process, red and green days have been introduced. A green day signals that a patient is moving through the system in a timely and efficient manner, whilst a red day indicates that progress has stalled and this patient will be flagged for review.
Well, the Red and Green Days initiative has been running now for several weeks within the organisation. It allows a very easy visual reminder of the progress of the patient through the path from admission to home. It allows us to quickly see patients where we think there are perceived delays and hence identify what we can do about those. Equally, it allows us to identify people who are moving through the pathway towards an estimated date of discharge.
In my opinion, I think we will have about 10 to 20% of patients who probably can be discharged. Even if it's a day or two earlier, that will create the capacity that you need for tackling the demand that we have on a day-to-day basis.
I think we're making huge inroads in our priorities for transforming emergency care, but I think we all feel as a team that we've got an awful lot more to do. Our performance is certainly stabilised over the summer period, but we're starting to sort of face some of the challenges of winter already. So some of the real key elements of delivery in terms of improvement need to be delivered in the next 2 to 3 months as a minimum.
We need whole system change, but then whole system needs everyone to get involved. It ain't the doctor, it isn't the nurse, it's not just the manager. All of us need to be working together on this. And clearly, the way that we're doing here in this trust is that it's very, very heavily clinically led, but well supported with our executive directors as well as the managers.